Hello, my name is Rob Ferry. I'm the point-of-care ultrasound program director at IU School of Medicine, and I'm going to talk to you about how point-of-care ultrasound can be used in the assessment of hypotension, particularly as it relates to this case that you're covering. So how does ultrasound help me assess a patient with shock? Well, there's two main ways. One is it assists in helping me determine the type of shock, especially if it's undifferentiated, and I still don't exactly know why the patient is in shock. The second is it can help me assess the response to treatment of shock. So first off, it's important to define shock. So shock is inadequate end organ perfusion. However, the way that we generally assess this in the clinical setting is by hypotension. Next, let's talk about our conceptual model. In the body, we have a pump. We have pipes that deliver blood to organs, and we can measure the pressure in the system. As the heart pumps, it generates pressure that then moves the fluid forward through the organs and then back to the pump again. Why do we have dropping pressure? Well, there's a couple of reasons. One is that the pump fails. Two is we obstruct the pump. Three is that the pipes in the system dilate, dropping the pressure. And four is we have leaking pipes. So cardiogenic shock is a type of pump failure. Here, the heart is pumping, but it's not pumping well enough to generate pressure. Next, we have obstructive shock. In obstructive shock, the heart's working, but it's not receiving enough blood because there's obstruction somewhere on the way to the heart. Third, we have hypovolemic shock. In hypovolemic shock, the heart's pumping well, but the pipes are leaking. This can be due to hemorrhage or from diarrhea or vomiting. And finally, there's distributive shock. In distributive shock, the heart works, but the vessels dilate, causing a drop in pressure. Septic shock is a type of distributive shock, and our patient who has hypotension from abdominal pain and has fever has a type of distributive shock. What is the physiology that's going on? So I have in distributive shock a drop in systemic vascular resistance, and because of that, and because of the increased oxygen demands on the body, there's increased cardiac output. On ultrasound, I can see this as a small IVC. In other words, because there's such dilation of blood vessels in the system, I have little blood that's actually making it back to the heart. This results in a small IVC and an underfilled heart. Because there's increased cardiac output demands, I will also see a heart whose left ventricle is hyperdynamic. When we perform a basic cardiac exam, we will look at four different views: our parasternal long axis, our parasternal short, our apical views, and our subcostal views. And finally, we'll also look at the inferior vena cava. So here's our parasternal long axis view in our patient. So as you can see here, the left ventricle is hyperdynamic. The walls are coming close together and they're almost touching. The right ventricle is also small and underfilled. Remember, the right ventricle should be about the same size as the aorta and the left atrium. In this case, the right ventricle is much smaller, indicating less blood is coming back to the heart. We can confirm this same look by looking at a parasternal short axis. Here we see that the heart's ejection fraction is very high, and while we should see the right ventricle in this view, we're really not seeing much at all because the heart is underfilled. Our apical four-chamber view essentially demonstrates this same thing. The left ventricle is very hyperdynamic, the septum and lateral wall are almost touching, and the right ventricle is underfilled. And finally, as we look at the inferior vena cava, we see that the IVC is very small and it collapses with any type of respiration. In fact, it collapses from beat to beat. This indicates that little blood is returning to the heart. We can see the same thing in hypovolemic or hemorrhagic shock, but in this case, the blood vessels are dilated because of the distributive shock, leading to less blood returning to the heart. But we can also use ultrasound to determine and assess response to treatment of septic shock. One of the mainstays of treatment to septic shock is IV fluid resuscitation. What should that result, or what should we see on ultrasound after that's completed? Well, we should see a bigger IVC with less respiratory variation as we increase the blood, or we increase the volume within the circulatory system to accommodate for this dilation of the blood vessels. We should see this as IVC being bigger, and the heart should not look underfilled any longer. So here's an example. After we've adequately volume resuscitated a patient, given them 2 to 3 liters of IV fluids, we can look at the IVC again, and in this case, we can see that the IVC is now full. There's less respiratory variation, and it's much larger in size. This is a good indication that we have adequately volume resuscitated the patient. So in summary, point-of-care ultrasound can help us to determine the category of shock. Conceptually, point-of-care ultrasound can help us as we think of the cardiovascular system as a closed system with pump and pipes. Failure of those pumps and pipes can lead to shock. And finally, point-of-care ultrasound can help us in assessment to our treatment and to see if we have adequately addressed the cause of shock.